Back pain, this is bread and butter, urgent care, primary care, and emergency medicine. Everybody needs to know how to deal with back pain. I didn't have any picture of anybody with a decent back, so I lathered myself up and took a picture. These things have to be committed to memory. If you don't know them, you just clip out the slide in your book or take and stick it in your pocket while you're working so that you know these roots and where the sensation is, where the reflexes are. They're really pretty simple, but you need to know them. Sensation is a little bit kind of interesting how the sensation kind of focuses, particularly around the perianal area. We'll focus on what the significance of that is in a minute. The overview. So yeah, really common problem. No surprise there. It's nice to know that you cannot give an anatomic diagnosis to the vast majority of these cases. We'll talk about some anatomic diagnoses, but for the vast majority of people whose back hurts, you won't be able to tell them what's exactly wrong. You can say you have a strain of your back and that'll go away, Frank, in a few weeks. But in terms of giving them anything more in terms of a pathoanatomic diagnosis, it's not going to happen. One of the common beliefs is that this stuff generally goes away in 6 to 8 weeks. And I've been, doing that mantra over and over and over again until we saw 2 articles in the database that really looked at people who had back problems, and I bet you know yourself or other individuals that this stuff can last for a year. Yeah, by the time that it's gotten less, but it doesn't mean it's not there anymore. So this idea of 6 to 8 weeks it's gone in the vast majority, that may be true for the majority, but there are going to be lots of people who do not meet this. One of the key things that people talk about in the management of back pain is to be encouraging to the people. It's going to be all right. Most of this heals up fine. You probably, we can have you rest a while. Maybe we'll put you in a little PT, otherwise known as shake and bake, to make it think like you were doing something while we wait for you to heal. These are the many causes of problems in the back. I don't know that we were meant to stand vertically. Some of them obviously are much more important than others, and we're going to focus on the red flags because that's really what it's about. Your job is to find the red flags. If you don't find the red flags, it doesn't matter because whatever else is there is going to get better on its own anyway. One of the things you often see in patients with back pain is they feel the necessity to attribute some event to why their back hurts. Well, it must have been when I was cleaning out the garage 3 or 4 days ago. I was moving a lot of boxes, stuff like that. So they feel to do that. And one of the things when they do that is that you swallow that story. As soon as you swallow that story, this is now a mechanical back pain thing. This is a strain from lifting the boxes in the garage. But you don't know that because the fact of the matter is that this person wants to find a cause and effect thing, and if in fact that is not the case, you will be misled. Where did I say? Yeah, this back exam, you should be a machine at doing a back exam. The issue of elderly people getting back injuries from ground level falls, I can tell you the elderly are terrified of falling. I know you wouldn't even think of that as kind of you in your own life, they're terrified of falling. A lot of them are using walkers. Some of them people who ought to be using walkers are not using walkers, and the older you get, I can tell you. I know a physician who's 84, is mentally fully capable and is really very much afraid of falling. I remember that we had a fellow who came into the emergency department, elderly fellow, he fell off the toilet and got lead wedged between the toilet and the wall. He broke his neck, falling off the toilet. Must have been quite a bowel movement he was riding down, but that's what happened. So here are some red flags. We'll do it more systematically in a second. So history of cancer, because cancers come back, particularly cancers that go to bone come back. Lung, breast, and prostate, lung, breast, and prostate, lung, breast, and prostate. Those are the big 3. But of those 3, breast cancer is the one that we can cure breast cancer. So a person has breast cancer 5 years ago, and next thing you know, they start having this nagging pain in their back, because breast cancer is one of the ones that recurs. Once you have prostate cancer, you generally have prostate cancer. So the idea is we're particularly concerned about that cancer. IV drug use is going to seed the bloodstream with bugs, and those bugs are going to land in some place, maybe in your back. The elderly, because of their frailty, anytime you have a fever and back pain, you may be in trouble. Anytime there's any issues regarding bowel or bladder function, again, another one of the red flags. Bilateral neurologic symptoms means that whatever is causing it is up in the back, not in the leg or in the butt or in the sciatic nerve kind of thing. History of trauma in the right age set, and thoracic back pain. Why would thoracic back pain be listed as kind of a, keep your eye out for this guy? Well, when you think about it, most of the time we have pain in the areas of our back that move. So our neck hurts, our lumbar area hurts because it's mobile. The thoracic back doesn't move. So the thoracic back is really kind of is a solid bar, more or less, doesn't move. Why would you have mechanical pain in an area of the back that doesn't really move? So you have to be particularly careful, and I'll give you some hints on how to look at the thoracic back pain. Red flags, we've got CBC's up, SED rates up, serum calcium, that's there. Cancer invades the bones, lung, breast, and prostate in particular. They are all common cancers. They invade bone. And in the process of invading bone, they can cause some elevation of cancer from nibbling away in the bone. But by far, the most common cause of hypercalcemia in cancer patients is the elaboration of parathyroid hormone from mimics of the parathyroid gland, and that's by far the cause. Once you have hypercalcemia in the setting of cancer, it's not a good finding. And I think one of the other things there is to point out, you got to order the right test. And when it comes to back, for bones broken and things like that, CT's fine. But for all the soft tissue stuff, CT's really not fine. It's MR, and I believe over time there's going to be more and more use of MR and less use of CT, especially as MRs get faster. Unfortunately, right now they're kind of slow. But our hospital is right near Caltech. They got all these engineers there. They got NASA. They have the JPL and all those kinds of things. A lot of smart people over there. And a young woman who was a postgrad student over there, was jogging at night. Exercise is just basically fundamentally dangerous. And she tripped on the curb and did a face plant into the street. And her whole face was all abraded. It was kind of bad, and she had broken a couple of teeth, and she had whacked her head, and she had a big thing on her head. And although she looked bad, she was mentally intact and all. And I said, we can do a scan of your head, but I honestly don't think you need one. And she said, oh, don't bother, Doc. We have a 7.5 Tesla MRI machine at Caltech. 7.5. We're putzing around with halves and 1.5s, and they got a 7.5 over there. So that's where this stuff is moving, I believe. No radiation shows a lot more. It's like when you do the head for a stroke. CT is not the study you want, really. Get that MRI, it tells you a lot more. Anyway, is there anything here that matters? Location of the pain? Well, I told you about the thoracic spine. Don't want to miss anything here. We're going to talk about sciatica more a little bit later. Here's the standardized back exam. You got to do it consistently. You have to have the patient's clothes off. You never want the patient to say, yeah, but my pants are on. It really makes your exam kind of, how could you do a good exam with the pants on, doctor? So don't let that happen. Don't let nurses be lazy. It's the expectation in the ER or in the clinic that all back pain patients will have their pants and socks off and a gown on. You basically, I will skip this. This is where we're getting sciatic nerve. Sciatica. The sciatic nerve is L4, 5, S1, and 2, and 3, and it comes together in a big rope-like bundle. All of these come together, and they go through the butt, and then they go down into the leg. Compression of part of this nerve or all of this nerve will result in pain going down the leg, potentially weakness in the leg, and decreased sensation in the leg. So we do the straight leg test. The straight leg test basically stretches the sciatic nerve, and if they have no pain while they're lying down and you stretch it and it causes pain, that makes us think that that's the problem. But do you know about the crossed straight leg test? When you raise the good leg and have pain going down the bad leg, you raise the good leg and have pain going down the bad leg. There's this terms about sensitivity and specificity. When you raise the good leg and you have pain down the back and bad leg, it's almost assuredly sciatica. Almost assuredly sciatica. This is part of the reflex thing, which is, there's a bunch of slides on this. I don't think we need to belabor this. You just got to know it. First syndrome, Piriformis Syndrome. This is a patient who has sciatic-like pain, and their back doesn't hurt, and their back is pretty flexible. They can do those kinds of things, and yeah, no injury. My butt hurts, and my leg hurts, and it sure does sound like sciatica. In a certain percentage of people, I think it's 15% there, the sciatic nerve goes through the piriformis muscle. The piriformis muscle is in the butt, and its job is to externally rotate the lower extremity, externally rotate. So this muscle, when it goes through the butt, when that muscle squeezes, it squeezes the nerve as well. And if there's some extra use of that nerve or muscle, or if there's some inflammation associated with there, that nerve gets entrapped and is causing pain when you externally rotate your leg, or when you press right in the center of the butt and it hurts there. You've made the diagnosis of Piriformis Syndrome. The idea here is, how do we resolve this? The idea is to basically kind of rest, maybe some NSAIDs, but you've made the diagnosis, Piriformis Syndrome. Vertebral fractures. These occur as a result of what we call axial loading. It's pressure down. You jumped off the steps here, pressure down, axial loading. If you see one fracture, the rule is look for others. And that's generally true. These are called non-contiguous fractures. So if you see a fracture, the most common fracture is L1, followed by L2, followed by T12, in terms of being compressed. Once you find one, you got to x-ray the whole spine, because there might be one up in the thoracic area. You need to find the others because of the phenomenon of non-contiguous other fractures. Significant trauma in the young, minor trauma in the old, it may be stable. It really depends on how far that vertebral body is crushed down. If it's just buckled a little bit, it's stable. If it's buckled down to a third of its normal height, then this may be an unstable fracture. Here's the x-ray. This is pretty subtle. You can count from the bottom. L5, 4, 3, 2, 1. That's it. Little crinkle there. Sometimes they're not particularly easy to see. They have to be careful. You can see that was pretty straightforward. So that's a small compression of L1, the most common fracture. Spinal stenosis. This is elderly people get spinal stenosis. The spinal column gets encroached upon because of thickening of the ligament flavum, or there's some facet hypertrophy. And what they get is a neat thing called pseudoclaudication. Now, you know about claudication from the vascular point of view, where somebody walks, and as they walk, they get pain in their legs. That is because there's a mismatch between the legs need oxygen for this motor activity, and the oxygen isn't being delivered because of vascular occlusion. So whenever there's this mismatch of I need oxygen, you're not getting oxygen, you get pain. So there's pain here. It's like angina in the chest. The heart says, I need more oxygen, you're not getting more oxygen, I get pain. Diane talked about ischemic bowel. Ischemic bowel says, I need more oxygen. You're not getting oxygen. Fine, we're going to have pain in your belly. It's all in the same modus operandi. So these people walk and get pain, and for all the world, it looks like it's vascular pain. But the fact is, it's really a problem with their spine. The nerves going through the spine are being compressed as a result of spinal stenosis. Some things that will help you make the diagnosis: it's aggravated on extension. I don't know that you're going to remember that kind of thing. They feel better when they can flex over and sit down. So if you wanted to, this is easily looked up. You're not going to see, this is a common diagnosis. Whether it's going to go to the emergency department or urgent care center is another matter. Spinal stenosis is really quite common. One of the good things about most musculoskeletal back pain is it gets better. This is not one of them. As you'll notice there, 70% remains stable, 15% gets worse, and this is contrary to the behavior of most back pain problems. This is an MR diagnosis kind of thing. Here's the idea. Now, the spinal cord, this is not the spinal cord being compressed, because actually the spinal cord ends at L1, L2, and this can be lower than that. So these are the nerve roots that are running down there. You know that corticline kind of jobber? That can be where that is. But the MR nicely shows that there's a narrowing of the spinal canal. So, and I don't know, frankly, that the CT would show this nearly as well. The MR is the right test. Spondylolisthesis, we've heard of this before. This is one of the young person's diagnoses. The vast majority of people have back pain are not young by any stretch of the imagination, but we're concerned here. So spondylolisthesis is slippage of one vertebrae on the other because of a crack in what we call the Scotty dog's neck. There's a young version and an old version. The young version basically could be due to induced by some exercise-related trauma, or it could be congenital. It's a slip of L5 on S1, where the one moves on from the other, and basically causes back pain in teenagers. Back pain in teenagers is not common, so you have to try and see if you can make this diagnosis. It is generally seen in the setting of hyperextension exercises. Who does hyperextension in the world of teenagers? Cheerleaders do a lot of hyperextension, if you look at what they do. Weightlifters do a lot of hyperextension in terms of what they do. Gymnastics. So the idea there is to take the x-ray in the young people. Normally we don't take x-rays in the young people. Normally we wait for things to see how it goes kind of thing. Take an x-ray because you want to see whether they have spondylolisthesis. If they do, they've got to stop doing the exercises that were precipitating this or aggravating this, because there are going to be more and more and more slippage. And you can envision to a point where the slippage is such that you even start compromising the spinal nerves that are in the canal. So this is one of the exceptions where young people would be radiographed, looking for spondylolisthesis. This is the picture of the one S5 on L1 is how this thing goes. When you take an oblique view of the lumbar spine, which is part of the x-rays that you take when you look for this, you get this bony configuration called the Scotty dog. And you can see in the bottom the Scotty dog, and the Scotty dog's neck is broken in one of those views. That means that there is a mechanical separation here, which can allow this shift to go. And the term for when it doesn't move forward is spondylolysis. Spondylolysis is I've got the defect, but I haven't moved. Spondylolisthesis, I've got the defect and I've moved. Meralgia Paresthetica, they'll think they're going to give you a raise if you get this one. So if somebody comes in and says, I get this really burning pain down the lateral part of my thigh. It really hurts like that. It's burning and it doesn't feel good at all kind of thing. This is compression of the lateral femoral cutaneous nerve. And if you point your finger right where the anterior superior iliac spine is just below it, and press there, you'll be pressing on the nerve that is generating this pain. One of the precipitants of this is These guys who wear the tool belts, heavy tool belts, it all centers right here. You see the cops that have all of these, you know, they got the billy stick, they got the gun, they got the mace, they got the handcuffs, they got their lunch on there, you know. So you can see that, or the workers that have the tool belts, that's another situation. Pregnant women, obese people are also associated with this. But you're going to be a hero when you say, hey, look, we got a good case here of Meralgia Paresthetica, if I can learn to say it. Here's some red flags. And honestly, if you learn one thing in back pain, it's this. So cancer, prior history with cancer, weight loss, that's okay. Age over 50, the numbers are kind of, there's a certain cutoff where you're allowed to take an x-ray because you're concerned it may be cancer without having defended. Some people say 50, some people say 55, some people say 60, some people say 65. There's no consistency in what that number is. I wish there was. I'm going to show you some guidelines at the end that say 65. Here we found a place where it said 50. There's that 17-year-old kid, though. Remember that the gymnast is the 17-year-old. He or she is entitled to an early x-ray. Again, no inciting event, even though they think that there is one. Lasts a long time, pain worse when you're in bed at night, lung, breast, and prostate. Infections are the ones we're really concerned about too. You got to circle this. We've said this ad nauseum, but I can tell you there's so many cases of missed spinal epidural abscess, and the outcomes are always bad. So you just have to have and these are more frequent than they ever have been. IV drug use, yes. Severe pain in the back, spinal surgery. The more hardware that you have in you, the more likely you are to get this process. And infections. If you've had a recent bladder infection, cellulitis, decubitus ulcer, pneumonia, whatever, it can seed into your back. And then if you're immunosuppressed, that just makes it all the more easy. Yeah, this is the idea here where if you find pain in the thoracic back, you be suspicious. And one of the things that you do here is you take your thumb and press right on the spinous processes during the whole back, right on the spinous processes. Pressing on the spinous processes will not cause pain for any musculoskeletal kind of thing that involves muscle. You know, the paraspinal muscles, those kinds of things, whatever it is, right on the spine. And what this does is it presses in, and these infections are usually right underneath the vertebral body where that spinal process is. So if you elicit pain by pressing on a spinal process, think it is diagnosis. SED rates are high. This is one of the things that you ought to consider doing. I got a temperature of 100.4, SED rate is 60. This is the diagnosis. You've made the diagnosis. You're a hero. MRI is the image. And here it is. You can get these abscesses in front of the cord or behind the cord. Here's an abscess in the area of the neck, C3 to C5. And in this case, you can see that the abscess is between the vertebral bodies, then there's the abscess, then there's the cord. So this is anterior, but they can become posterior as well. And they can be quite long. And one of the things that has been shown is you cannot reliably determine the area of the back where this thing is occurring. So you have to do the whole back. Don't say, oh, I think it's in the neck, because you can miss it if you do that. The Thoracolumbar syndrome is basically a sudden onset of back pain. I can't pee, your bladder is distended, your rectum is dilated, you're dropping feces on the floor, kind of thing. And it's a vertebral collapse. It's a cancer that is bored into the supporting structures of the back, causing a collapse. These nerves that come out of the spine around L1, L2 run down the back. They're getting pressed in the spinal canal, and they have bilateral pain in the legs. Doesn't have to be bilateral. Pain in the legs, weakness in the legs, urinary retention. You may have overflow with that retention, and the anal sphincter is loose. And there's this saddle anesthesia business. This is a bad disc herniation causing called a equine, a horse's tail. That's why it's not spinal column. It's these individual nerves that are running in the spinal column, waiting to go out of their ostia down the road a piece. The workup, you can do a CBC and sed rate if you think that somebody's infected. Have a low threshold for doing a sed rate in these cases, absolutely. Checking the calcium is, you can do that. You can do that. Specifically, here's the issue about the age. These guys say 65, and I'm going to show you the list of the American College of Physicians guidelines here. Get the right study. Get the right study. And I'm not going to read these to you. There's four slides of this. This is the official policy of the American College of Physicians and American Pain Society about when you ought to get x-rays, how long you ought to allow patients to heal up before you get x-rays, what would be the indications for getting x-rays downstream, those kinds of things. And when you read it, you'll find it is extraordinarily conservative. They're not interested in you getting x-rays on the first visit to the urgent care center or to the clinic if somebody has what appears to be musculoskeletal back pain, if the history is right and there's no likelihood of having one of the red flags. They basically say back off. And one of the reasons that they say back off is, look at this slide at the bottom. Here's how much juice that you get from x-rays. So if you x-ray the plain old thoracic spine, it's 35 chest x-rays. No big deal. Lumbar spine, 65 chest x-rays. Head CT, 115 chest x-rays. Chest CT, 400 chest x-rays. Abdomen and pelvis, which we do 25 times a day in the emergency department, that's 500 chest x-rays. Chest CT angiograms, chest CT angiogram, we're up to 600 now. That's for when you're looking desperately for this PE, 600 chest x-rays. The lights in the hospital dim when that's happening. Oh, a chest CT is being done, the whole hospital knows. CT of the thoracic spine, 900 chest x-rays. CT of the lumbar spine, 950. CT of the lumbar spine. Can you imagine what is happening to the gonads at 900? It's like, just take them out, They're going to turn out to be little raisins by the time you get that thing done. So that's equivalent to 8.8 years of natural exposure. In terms of treatment, the idea is you're going to do fine. Don't get discouraged. It's going to be okay. It's going to last a while. I'm here to help you. All about encouragement. Sure, you can have a little pain medication, even for a couple of days. We can get you some bed rest for a couple of days, but they're not supposed to be laying around bed for a long time. I'll give you some strong pain pills if you need it. Otherwise, we'll start using some more mild stuff. Muscle relaxants are basically for your head, not theirs. Muscle relaxants none of them relax any muscles, kind of thing. They're all sedatives. They're all going to make you sleepy, groggy, those kinds of things. But there's nothing, whoever came up with the name Flexeril should have gotten this huge bonus. Hey, we're going to give you some Flexeril, God. And that's it. And give them some time and get to see them again. Some of them may want some PT. That's fine too. Won't make a big difference. But in any case, thoracic back pain, one of the core subjects of emergency medicine and urgent care and family practice as well.